Thank you. Very excellent discussions on GAT. A quite typical discussion now about the neovascular glaucoma. My experience. I am a invited guest faculty from Bangladesh, and I wanted to share my experience on neovascular glaucoma. I don't have any financial interest doing this presentation. I want to start with a case presentation. A 50 years old male, diabetic for the 15 years, came at our institution with sudden painful reduction of vision with watering and foreign body sensation. Patient was diabetic for the long time. Patient vision was hand movement. There is no improvement with the pinhole. And this is the condition of the patient, the huge bullous keratopathy with 46 intraocular pressure. This is the more magnified view. I started benzolamide, brimonidine tartrate, timolol, and I started with carbonic anhydrase inhibitor. And also I admit the patient with, I have given 20% mannitol for the preparation for the operation. And after mannitol, intraocular pressure was 30. The cornea is almost clear in the day after giving the mannitol. And this is the condition of the patient in the second day. The again rebound raise of intraocular pressure of 45 millimeter of mercury. And what are the challenges in this case is rebound raised intraocular pressure, endothelial decompensation, failure of conventional trabeculectomy. So I have planned to do the Ahmed glaucoma valve implantation. In this case, the quality of video is not very good. So the tube is going to be fixed. I used to use the self-sclera flap, trimming of the tube. Perfect tube placement is very much important in this case, as the corneal endothelial is almost decompensated. So this is the post-operative follow-up. You can see there is no bullous keratopathy and tube in the anterior chamber. And after 7 days, intraocular pressure was 15 millimeter of mercury, and the vision was improved. And this is the picture of the 7th post-operative day. So in the visual acuity was hand movement, and after 1 month it is 636. Intraocular pressure is 46 millimeter of mercury. After Ahmed valve implantation, it was 15 millimeter of mercury. There is a huge improvement of the vision. So angle neovascularization, in my experience in my country, is the two types of neovascular glaucoma. One is open angle glaucoma, one is angle closure glaucoma. Angle closure glaucoma used to develop due to fibrovascular contraction later on. And in that case, when there is an angle closure neovascular glaucoma, in that case the postoperative outcome is really challenging. And in my country, the commonest cause of neovascular glaucoma is diabetes plus CKD, CRVO, CRAO, vasculitis, sickle cell anemia, and Coats disease. And this is the pathogenesis like hypoxia, VEGF induction, endothelial proliferation, ANG2 induction that may cause the angiogenesis. So the management protocol is to use the mydriatic and cycloplegic anti-glaucoma, but no prostaglandin or pilocarpine, steroid eye drop for a little period, topical NSAID, and anti-vascular endothelial growth factor, which is given by our retina specialist. And surgery used to do trabeculectomy with MMC or trabeculectomy with collagen implantation if it is an open angle. GDD, glaucoma device, glaucoma drainage device, valved or non-valved. Used to use the Ahmed valve and Barvelt. Adi is not available, so much available in our country, and sometimes cyclophotocoagulation. Transscleral cyclophotocoagulation has some role. I have some experience with doing this with cyclodiode. If patient has a very much painful blind eye with almost NPL vision. Endocyclophotocoagulation is also going on there. So I want to show you a video of 20 years old by poor socioeconomical background. Cataract operation was done. Secondary glaucoma, patient has a secondary glaucoma after cataract operation, and ultimately patient developed neovascular glaucoma later on. And patient underwent trabeculectomy. Ultimately, it was failed. IOP1 not control with highest medication, and plan for non-valve tube implant. It's a very short video. Actually, tube is going to be inserted. So usually I used to use the tutoplast for covering the tube. So my take-home message is, no doubt, glaucoma genius device implant surgery is a good option for refractory glaucoma, especially in the neovascular glaucoma, and it reduces patient mental and financial burden and improves social life. Thank you. Thank you for patient hearing.
Sir, do you do diode CPC in some cases, or to reduce the pressure, or you
No, in some cases where the patient has a like hand movement vision with some PLPR in the one quadrant, in that case, and patient has a severe intraocular pressure with painful eye, and it looks that even Ahmed glaucoma valve is not very much suitable on any valve. Even the most important thing is where the patient cannot afford the Ahmed or Bearwell, because we don't have the Adi in our country still. We have Bearwell and Ahmed.
Okay, and sir, for eyes with visual potential, you will directly go for GDD.
Yes, no, directly go for GDT.
Sir, any indications where we will use AGV and where you will use Barwell?
No, actually, but in my country, we used to use Ahmed glaucoma implant mode, because Barwelt is very much expensive, and I don't have any selection where I will have the Barwelt, because Adi is also prototype for Barwelt. So but in case of very high intraocular pressure, it is a 50 or 60. In that case, I preferably use Ahmed valve implant, because in the Barwell implant we have to cross. Yes, hypertensive phase was there, and patient has an advanced glaucoma. In that case, I used to use the Ahmed implant to avoid the wipeout.
Okay.
Thank you.
Sir.